So today's topic is a little bit away from the core of the parasites, bacteria and everything that we have read so far. This is a very important topic for hospital infection control. Some of you in your batch will be microbiologists, I hope, and those people will be the hospital infection control officers. And they will have a huge task in preventing the infection in the hospital. So you have to prevent the infection from one patient to another, and you have to prevent the infection from the patient to yourself, right? So environmental surveillance maniki, we need to see the environment, that the hospital environment is clean and disinfected in a regular timely manner, and it doesn't pose a threat to the patient. Suppose a patient has come for a bone marrow transplant. Okay. Now you put the patient outside the BMT ward. That BMT ward was actually for the patient, but you did not have any bed. So you have put the patient outside the BMT ward in a private cabin. Now that patient develops fever. There may be 10,000 reasons for the fever, but one of the reasons are that the patients might have contracted some organism from the room that you have kept the patient in, because that room was not monitored. That room was not supposed to be catering a BMT patient, because all the marrow transplant patients are immunocompromised. HIV patients are immunocompromised. Cancer chemotherapy patients are immunocompromised. CKD patients, CLD patients are immunocompromised. So all the immunocompromised patients, you have to take care of the patient that they doesn't get infected from the hospital environment. Now, what do we mean by environment? Three things: water, air, surface. Surface may be anything. It may be the surface of the bed, it may be the surface of the food trolley, it may be the surface of the IV stand, it may be the surface of the walls, floors, anything. Water will be the water that is supplied through the pipeline. It will be either potable water or it will be either RO water, reverse osmosis water. And air, you can see that air is very, very important for operation theatre also. For laminar OTs or green OTs, you need to have certain parameters which has to be monitored every day. What are those parameters? Air pressure. How much air pressure is there inside the OT? First point. Second point is humidity. They should have a fixed humidity inside the room. Third point is the temperature. There should be a fixed temperature inside the room. So all these things are written in the guidelines. You cannot practice beyond guidelines. Okay. And also the air quality, because you see nowadays the OTs are fitted with HEPA filter. So any place where HEPA filter is fitted, you need to check the expiry date of the HEPA filter. You need to check the validity of the HEPA filter at their interval that is recommended from the company. Few other companies, they tell that HEPA filter should be checked 6 monthly. Few other companies, they tell HEPA filter should be checked yearly. Mostly it is yearly. So HEPA filter needs to be validated that it is working, and then they will give you a certification. Okay, fine, my HEPA filter is working. And every month I should get a air quality check, that how much percent of organisms are present in the air. What organisms are present in the air? Because if my air is dirty, if my AC, HEPA filter is expired, then when I am opening an abdomen inside a OT, when I am doing a cardiothoracic OT, when I am opening the chest, so the patient is open for about 1 hour, 2 hours, 3 hours. If the air quality is not good, then if one microorganism entered the system, sterile body cavity, then it can create a huge problem. The problem will be SSI, surgical site infection. Okay. Now moving forward, as I have told, these three things are essential: water, surface and air. See, you don't need to have a detailed knowledge about how to calculate, the colony counts, how to calculate the tubes and everything, but you need to have a basic concept as in what has to be done for environmental surveillance. The intention of my class today is to give you a map of what is happening in the hospital. Okay, don't read the numbers and everything, so you'll be confused. Okay, so as I have told, the surveillance is required to prevent the infection. Okay, sometimes you see hospitals are also accredited by many international and national accreditations. For example, the hospitals nowadays are accredited by NABH. NABH, have you heard the name? NABH? No? Okay. So NABH is a national body which gives recognition to hospitals, and they have a fixed standards and criteria. So if you are meeting their criteria and standards, basically they are very high criteria and standards. So if a hospital is NABH, then it gives a impression, and it gives a quality that there will be certain standards that will be maintained in a hospital at all the times. So NABH also gives fixed guidelines about environmental surveillance. We cannot skip that. In the audits, they usually see how much we have dedicated ourselves, or how much we have gone in depth for the surveillance of water, for the surveillance of air, for the surveillance of surface. So all the documents you have to produce them physically. So that's a requirement. Okay. Now, indications. So when will you do it? You cannot do the air, water and swab, surveillance surface cultures every day. You need to have a policy. Okay, fine, I will do the swab samples once a month. I will do the RO water testing 6 monthly. I will do the air quality checking once a month. So each zone or each OT of the hospital, each area of the hospital, you need to have a SOP, standard operating protocol or standard operating procedure. So in that SOP, it will be written which area, how much frequency it has to be done. Suppose your hospital has had an outbreak. What is outbreak? Outbreak mane ki? Yes, first bench. Spread of what? Disease. It's a very vague, non-scientific words that you are saying. Spread of a disease. Spread of a disease can be epidemic. Spread of a disease can be endemic. But what is outbreak? Don't know. How did COVID spread in China? Was it an outbreak, or was it a pandemic, or was it an epidemic? See, I'll tell you a very simple thing. COVID was existing, or maybe, okay, fine, leave COVID, influenza. So we all have influenza cases in West Bengal, right? So maybe the cases will be 100 per month, for an example. So your baseline is 100 per month, the frequency that will be existing all over the year. Okay. Now suppose in the next month you have 20,000 cases. So that has exceeded the baseline. So in any point of time where the disease incidences, it increases from your baseline at a particular point of time, at a particular geographical area, which is not normal to that area, can be called a outbreak. Okay. And then the investigation has to start, as in where and how the disease has broken off, or the disease has spread. So you need to learn what is outbreak, what is epidemic, what is pandemic. These are all three different things. So whenever your hospital is having an outbreak, you need to have the surveillance culture from all the three things: air, water and surface. When your hospital is going for a research organization or research development also, then you can have this surveillance cultures. For quality assurance, as I told, and yes, if suppose there is a big construction work in your OT, if suppose the OT is being renovated or something, or if there is a construction in ducting, or if there is a construction in the HVAC system, then the again repeat surveillance culture has to be done, so that there is no remnant microorganism in the system. Now coming to the microbiological air sampling, now I'll tell you, air sampling, it depends on many things. Suppose this classroom was empty for 1 week. Do you think there will be so many organisms inside? No. And suppose the next classroom, every day there are 2 classes that are held with 100 students. So in which place do you expect microorganisms to be there? In the next classroom, correct? So more the humidity, more the number of people trafficking the area, more the number of doors, more the air circulation. So all these things, they tend to give rise to the rise in microorganism in the air. So that is important. Which OTs are very, very much precious to us? Yes, a OT that is giving incision and drainage. Is it high priority OT? No. An OT that is doing a TKR, is it a high priority OT? Yes. What is TKR? Total knee replacement. That means there will be a joint prosthesis that will be given. So whenever you are giving an implant to the patient, if the implant is infected, then the patient lands up in a deep trouble. There will be a SSI involving the implant. So you have to take the case, remove the implant, and then give further treatments. Okay. So there are a few like high priority OTs like cardiothoracic surgery, like orthopedic surgery involving the implants, like transplant surgeries. So these are the things that needs to be monitored very cautiously. Okay. So as I told, operation theatres, intensive care units and wards. Wards doesn't require generally, but the wards catering the positive pressure ventilation. As I told, immunocompromised patients like bone marrow transplant patients. So those wards needs to be monitored very frequently. And intensive care units, of course, because there are so many patients that are dealing with each and every day, having CKD, ILD, CLD and all those things, they are immunocompromised. So your ICUs need to have a proper control of air, surface and water. Okay. So those all things has to be, it doesn't have to be microbe free, but it has to have expected level of microbial contamination, which should be below that level. So we have a standard, it should be below that standard. Okay, this I have already told when to perform the air culture. Now, yes. Now there comes how to perform the air culture. There are many methods. There are 7 methods, but we don't do all these things. Generally, we either do a active monitoring or we do a passive monitoring. In these two, there is less cost in passive monitoring, and 50% of the hospitals, they do passive monitoring because there is less manpower needed. You don't need any specialized instrument. All you need is a culture media plate. That's all. Okay. Active monitoring mane, see, the basic principle is, এই যে ফ্যানটা চলছে, এই ফ্যানের তলায় যদি আমি একটা এরকম হাত পেতে দাঁড়াই, তাহলে there will be some microbes that will be coming onto my hand. I cannot see it. But if I place a culture media and place like this for 1 hour and then I incubate the plate, the next day if I see the growth, there will be growth. Okay. So I am keeping the culture media plate on some clean disinfected table, which is 1 meter above the ground, 1 meter away from the wall, and I will be opening the plate and keeping it for 1 hour. So it is a 111 rule, 1 meter, 1 meter, 1 hour. And then I have to close the media and keep it in the incubator. Okay. So this is the passive air sampling, means I am not forcing the air onto the culture media. But there are some machines, if you place the culture media plate into that machine, it will draw the air by a motor. It will draw the air and it will forcefully feed the air onto the surface of the medium. So that is the active air sampling. So that is the first point, that is sieve sampler. I think I have a diagram or a picture of sieve sampler. And the 111 rule that I told applies for the settled plate method. That's what we call the settled plate method. You see, this is the plate, culture media plate, that is placed in a slanting fashion, 1 meter above the ground, 1 meter away from the wall, and it will be open for 1 hour. And then you take the plate, close the lid and put it in the incubator. And incubate for 24 hours at 37 degree. And you see the microbial contamination. You count the number of colonies and you find the contamination. Now this is the active air sampler, where you put the plate here and there is a a channel around the plate. So through that channel the air will be sucked in and the air will be forcibly hitting the surface of the culture media. So many people they use this, but most of the places they don't have this instrument because it is costly. I think it costs around 1 lakh or 2 lakh something. So instead of investing into this, they can easily do a passive air monitoring that is equally good, no problem in there. So you don't need to focus on these conversion tables. Now this is the acceptable limit of contamination. So we generally measure the index microbial contamination rate, or we call it IMA. Now the Switzerland has some standards which says the acceptable limit at rest. So whenever the room is empty, there is no movement. So the acceptable limit is less than 5. Whenever the room is functioning, then you take the air culture, the acceptable limit is less than 25. Okay. So this is the acceptable limit of the colony forming units in the plate. Now whenever, so this what does it mean? So if I take, suppose I have taken this OT air sampling and I have found that there the colony counts are 100. So that means that the OT air is not good. I cannot operate a patient in that contaminated OT. If I do, the patient may end up in having a SSI. So what do we have to do? We have to stop the room for functioning. We have to vacate the room. We have to tell our housekeeping persons, you have to clean the room, disinfect by deep cleaning. So that is the word that is used, deep cleaning. So they will deep clean the room and then they will do a fogging. Fogging means the quaternary ammonium compounds, the disinfectants, they will be aerosolized inside the room. There is a fogger machine ache, jar moddhe diye you can spray the disinfectant and it will be covering the whole room. So you have to keep the room locked for 1 hour and then you will open. And then you can take another air sampling and then you can start the OT if the air sampling is negative. So these are the things that are done. If after deep cleaning the room also there is growth of microorganism, then you have to check the HEPA filter of the room. You have to call up the biomedical department. They will come, they will check the HEPA filter. If it is needed, they will replace the HEPA filter. Mostly the organisms that are transmitted from the HVAC system, that is the air ventilation system, are fungi, aspergillus, very important. So if your OT has many aspergillus colonies on the plate, then it is very difficult for you to do a transplant or whatever surgery you want to do, because that room will be completely not clean for the patient. So it is not recommended that you do OTs in such area. Okay, so this I was talking about. See the temperature parameter here, it is written of the OT. It should be 21 plus minus 3 in the general OT, and for the orthopedics implant OTs it should be 18 plus minus 2. For humidity it should be less than 55 to 60%. So it is around maintained around 40 to 60% it is maintained. The positive pressure is maintained 2.5 pascals. So that is, these are the 3 things that you should have in the checklist. daily checklist whenever you are starting the OT and whenever you are ending the OT. So, these three things should be maintained. Okay. Now, coming to the water sampling. Why do we require a water sampling? হ্যাঁ পেশেন্টকে তো আমি বিসলেরির জল কিনে দিলেই হয়ে গেল। ওয়াই কি লাগে জল কিসের জন্য কাজে লাগে হসপিটালে? Scrubbing. Okay, so you need water in the OTs for scrubbing. Okay, next, do you need water in the wards or ICUs? No, লাগে তো কিসের জন্য লাগে জলটা আইসিইউতে? Have you gone to the ICUs? No, you have not gone to the hospital also. কোথায় গেছে হসপিটালে? ফার্মেসি? Then you should visit your ICUs, you should visit the wards, you should see how it is. No? What is the important thing in microbiology, in infection control? Standard precaution, first point ki ache? Hand hygiene. So after touching a patient, you should do a hand hygiene. So you should have a water supply to wash your hands, right? So ICU te you should have a water, basin, a tap, a soap. লাগবে তো হাত ধুতে? দেন আইসিইউতে ডায়ালিসিস হয়, এমার্জেন্সি ডায়ালিসিস হয়তো। ডায়ালিসিস জন্য কি লাগে? আরও ওয়াটার লাগে, রিভার্স অসমোসিস ওয়াটার। সো ইউ নিড ওয়াটার ফর ডায়ালিসিস, you need water for hand hygiene. Okay, and there are so many things that you need water for. Okay, some areas of the hospital they will do primary instrument washing, but it is not recommended. You see, if you have a CSSD, that is Central Sterile Supply Department, you should not wash your instruments in the wards, OTs or cath lab or whatever it is. You should send all the instrument to the CSSD, they will do the washing. But due to some constrictions or due to some problems, some people they will wash the instruments in the OTs. So in that also water is needed. So it is very important that you have proper water supply and that water supply is monitored, because you don't have any idea how much contamination a water supply can give. The important thing is the most important hospital bug, that is Pseudomonas. Pseudomonas is famous for forming things called biofilms. What are biofilms? Biofilm is a self-secreted extra polysaccharide matrix in which the bacteria will be surviving happily. How much antibiotics you give, it will not penetrate the biofilm. And it is the major cause for implant failure. Orthopedic implant failure, major cause. Once the patient develops biofilm, you can do nothing. You just have to open the area, throw away the implant. That's all. So Pseudomonas is a very notorious bug that forms biofilm, and it will form a biofilm inside hospital water supply. Inside the pipelines, they will form a biofilm. So that is very important, and we are not so much worried about Legionella, because that is not very much in having a high frequency in our part of the country, but the western population, they are concerned with Legionella. And you see coliforms, sometimes it happens that the hospital water supply can be contaminated underground with the fecal water or the fecal pipeline or something. And then you can find that in your drinking water, in your hospital clean water, you can have a cross contamination with the coliforms. So you can have E. coli, Klebsiella in your potable or RO water also. So that is a huge thing that you can have. Burkholderia, Stenotrophomonas and Sphingomonas, these three pathogens, they are water loving bugs. So they will exist in water. কোথায় কোথায় থাকবে? Distilled water that you give for injections, dilution solutions, dialysis machines, nebulizers, very important, and ventilator temperature probes. Nebulizer এর মধ্যে কিন্তু প্রচুর থাকে, নেবুলাইজারের যে জলটা ইউজ করা হয় না, if you don't throw away that water, oxygen the humidify করার জন্য যে জলটা ইউজ করা হয়, if you don't clean that humidifier, then it is a big problem. Your patients will be having LRTI with these bugs and you will not know যে কোথা থেকে আসছে. Okay, then you call up your infection control officer and then they start an investigation. So Legionella, I have told, Acinetobacter, Enterobacter খুব একটা হয় না, but yeah, they can, Acinetobacter can colonize ventilator machines and they do. They are the main cause for ventilator associated pneumonia across all the hospitals, followed by Klebsiella and other bugs, but Acinetobacter is very, very important. They are causing a massive LRTI in the hospitalized patients. Okay. Next, yes, non-tuberculous mycobacteria. This is very important because you see all the stains that we do it through tap water only, right? In a rare case we use distilled water. Ideally we should use distilled water, okay, but mostly tap waters are used. Now your hospital, tank is a susceptible place for mycobacterium, not the non-tuberculous mycobacteria to harbor, because they will be colonizers, they are contaminants. So if they are contaminating your hospital tank, now I am doing a Zn stain with that water, so all the patients are Zn stain positive, correct? So that is very harmful. So you should see frequently that the hospital water is checked. And the other things like Cryptosporidium, Giardia can be found, but that can be found, but that is also rare. Yes, so as I was telling, ingestion of water, the patients who have normal diet, they can have the contaminated water from medical devices. Contact transmission can occur. Suppose you are having endoscopy department, so endoscopes are generally, they are disinfected. By which solution? They will be either using peracetic acid or they will be using orthothalandehyde or glutaraldehyde, whatever the policy says in the hospital, and then they will be rinsed in sterile water or RO water, whichever it is recommended by the company. Okay, mostly it is they will be rinsed by RO water. So if your RO water is contaminated and if your RO water is having suppose non-tuberculous mycobacteria inside it, so every case you are doing an endoscopy, you are giving that non-tuberculous mycobacteria to the patient, right? Every case you are doing an endoscopy, you are giving Acinetobacter to the patient. So that is a kind of a massacre, you can tell. Inhaled aerosols from water sources and aspiration of contaminated water, these cases you can find in the ventilated patients. Okay. The routine testing of water is not recommended, but if you read the guidelines of the latest NABH, if you read the guidelines of the other accreditation standards, they say that water has to be tested at frequent intervals for dialysis. It's very important. It depends on how many dialyzers you have. All the dialyzer input port has to be tested at least 6 monthly. If you do it monthly, there is no harm, but you have to test. Okay. Now, the previous slide, yes. Okay, sampling point I will just tell you later. Yeah. So this is how you should collect the water. You don't have to collect the water, but you should know how to collect it and in which container you should collect. Mostly the glass containers are used, which is screw capped, and it should be just be treated like a urine sample. After the collection, the sample should be sent to the lab as soon as possible within an hour, and then it should be processed immediately. At least 150 to 200 ml of water is recommended, but we generally we sometimes take less also. So that's not a fixed thing that you have to do. Now sampling method, I will just tell you this, that there are two sampling methods. One is a pre-flush and one is a post-flush. In details you don't need to know. Okay, pre-flush technique means whenever you are rinsing something in the tap, if you are not keeping the water running for some times, it is a pre-flush. So when you start the tap, it is a pre-flush. When you start the tap for some times, keep the water running and some water is discarded, and then you take the sample, it is a post-flush. So that much you remember. So this is exactly how you should take the water sample. You have to clean the tap, you have to turn the tap on, and then you have to turn it off to pass some water. So you should not take the first, it's like a midstream urine. Okay, you have to let some water flow. So this is a post flush technique. You have to sterilize the tap outlet because you don't know what organisms are there. So either you have to soak it with a alcohol swab and then turn the tap again, and then you let water flow for 1 minute and then you collect the water. So this is how you should do the post flush technique. Now what we do is we deploy some tubes for the culture. That is called MPN. So MPN is expressed in 100 ml of water. So the broth that is deployed is McConkey purple broth. Remember the name. Details procedure is not needed. So McConkey's purple broth is required, and for thermotolerant E. coli we used brilliant green bile broth. I have a picture, yes, this one. So this is called Ekman test method, where we confirm the thermotolerant E. coli. Brilliant green bile broth. Few cases they also do the membrane filtration method, but we mostly do the tube methods. Now in the dialysis unit, as I was telling, that dialysis unit requires you to culture the water, that is fine, but they also require something called endotoxin detection. Endotoxin detection means that if a bacteria was there in the water, they will be releasing some endotoxins. If the bacteria is dead, the endotoxin will also be there. It will not go away because endotoxin is the lipopolysaccharide of the bacterial cell wall. Correct? Now, if this water is contaminated and it enters the dialyzer machine and it enters the patient's body through the RO water, then the patient will have shock. Patient may have fever, patient may develop some sepsis. So many things can happen to the patient. So you need to do a endotoxin assay, and there is a crab called horseshoe crab. From that horseshoe crab, the blood cells, there is an extract called Limulus amebocyte lysate, LAL. Okay, that extract is used to detect endotoxin, because with endotoxin, that LAL extract, it causes a clot. So also we call it a gel clot assay. So that's how we measure the endotoxin in the water. Okay. Yeah. So whatever you find in the water, suppose you have found E. coli, then you see a coliform organism is found, then it must be that there is a cross contamination with the sewage line to the RO water line or something. Okay. If you find Pseudomonas in the line, then the whole line should be having a check for the biofilm. So like that, the organisms it is found, the corrective action depends on the organism's type. Now these and all we will skip because this is not required. Now the last portion is the surface sampling. Surface sampling means what? We have to culture the surface. That surface will be the high touch surfaces. What is a high touch surface and what is a low touch surface? Tell me. In this room, what is a high touch surface? High touch surface মানে কি? হ্যাঁ, মানে হচ্ছে যে সারফেসটা ইউ আর টাচিং ভেরি ফ্রিকুয়েন্টলি, So that's a high touch surface. In a ICU, which is a high touch surface? Patient's bed, okay, and IV stand and the handle of the door. সবসময় সবাই দরজাটা খুলছে, এখানেও তাই, handle of the door. So at any point of time, you take a culture from the handle of the door, you will get some microorganism, 100%. Okay. So high touch surfaces needs to be cleaned at a very frequent interval, and that needs to be monitored. Okay. So how will you monitor? There is a simple method. You take a swab, you put some sterile normal saline in the swab, that is moisten swab, and you take the swab from that surface, that's all. And you take the swab to the microbiology, they will put it into a culture media and you incubate the pig. Story ends. Okay. So we do a swab culture, a sterile swab moistened with normal saline, and then we put the sample, that's all. So 1 minute একটু পিছিয়ে যাও কি হচ্ছে রে, এরকম খারাপ জিনিস কেন? হ্যাঁ, এটাকে বলো চেঞ্জ করে দিতে, লাস্টের দিকে যাও। So I'll just tell you which surfaces needs to be swabbed. একসাথে 5টা স্লাইড স্কিপ করে দাও। Yes. So you see, these are the high touch surfaces that needs monitoring. What are these things? Bed rails, then frames, movable lamps if you have, tray table, bedside table, handles, IV poles, and blood pressure cuff, very important. I don't see people disinfecting blood pressure machines between 2 patients, but NABH standard or any international standard that you take or any national standard that you take, it gives you a direction that whenever you are using a stethoscope to one patient, before moving on to the next patient, you have to disinfect your stethoscope. You have to disinfect your thermometer. You have to disinfect your blood pressure machine. But do you see it happening? So there is no internationally acceptable standard for surface sampling, and some guidelines that say that surface sampling, the bacterial load should be below 5. So below 5 it is acceptable. Okay.